Greetings from Lucknow, India. My name is Dr. Kshitij Shankhdhar and I am a diabetologist. The topic of my presentation is debridement, making more with less in India. Now, debridement is defined as the removal of dead, non-viable or devitalized tissue, infected or foreign material from the wound bed and surrounding skin. As one can see in the first picture, the lesion is there and the devitalized tissue is there, and in the second one, debridement has been done and the devitalized tissue has been removed, and in due course, healing happens. Now, why is it necessary? The devitalized tissue can form a physical barrier that prevents new epithelial cells moving from the wound edges to provide a new covering of epithelial tissue. The devitalized tissue can block the delivery of topical preparations, that is, antimicrobial therapies, preventing them from penetrating the wound bed. Wound assessment is hindered by devitalized tissue as clinicians are unable to accurately gauge the extent of a wound. Biofilm barrier to chronic wound healing is present in 60% to 90% of chronic wounds. Debridement as part of a multiple concurrent strategy for wound care is an effective tool for the suppression of biofilm. Frequent disruption of biofilm provide a clinical opportunity as the biofilm is more vulnerable to antibiotics during the recovery phase of the biofilm post-debridement. A combination of debridement, rapid molecular diagnosis of infecting agents, topical application of treating agents, and systemic antibiotics is found to be highly beneficial clinically. Now, there are different types and different options for debridement. The mnemonic is BEAMS: biological, enzymatic, autolytic, mechanical, and surgical debridement. Now, biological debridement is the use of maggots. Enzymatic debridement is performed by the application of a prescribed topical agent that chemically liquefies necrotic tissue with enzymes. Autolytic debridement uses the body's own enzymes. Mechanical debridement is done by irrigation, wet to dry dressings, etc. And surgical debridement is performed using surgical instruments. Mechanical debridement, use of an outside force to remove non-viable tissue, for example, wet to dry gauze. Enzymatic debridement, for example, use of collagenase. Sharp debridement, using scalpel. Autolytic debridement, use of hydrocolloids. And biological debridement, for example, larva debridement therapy, or the medical grade maggots used for debridement. Now, different types of debridements have different clinical factors which must be kept in mind. And then in a given case, a type of debridement should be chosen as the most desirable method of debridement. For example, when speed is priority, surgical debridement is considered better when there is infection and exudate. Although when tissue selectivity is the priority, then enzymatic debridement is considered better. And when cost is the priority, then autolytic debridement is considered better. So in a given case, different type of debridement method could be chosen. Who does the debridement? Trained healthcare providers, for example, doctors or nurses, are considered responsible for doing the debridement, although it has been published that there is a misconception that debridement is solely the responsibility of the tissue viability nurse specialist. In reality, the majority of patients who require debridement as part of a package of holistic wound care are not under the management of a tissue viability nurse. Rather, it is the generalist nurse who often has initial and ongoing responsibility for wound assessment and the delivery of continuing care. A certain checklist should be kept in mind while making the debridement decisions. For example, what is the goal for the wound? Is the debridement appropriate for the wound? Should I take a conservative approach? Should I actively try to accelerate the wound healing process? Am I certain what to do? If not, then it's better to consult multidisciplinary team. How do I accelerate healing through debridement? Have I discussed the debridement option with the patient family members? Do I have the skills to perform the chosen method of debridement myself? What are the expected outcomes of debridement? Options at given stage. When to avoid debridement? Debridement is not appropriate for dry necrotic tissue or gangrene without infection, as found in the ischemic diabetic foot, where the most appropriate decision may be to leave the devitalized tissue to dry to such an extent that the necrotic tissue separates from the limb, that is autoamputation. For example, in this case, one can notice dry necrotic tissue, gangrene without infection, ischemic diabetic foot. So the appropriate decision is to leave the devitalized tissue to dry to such an extent that the necrotic tissue separates, and this is what was done. The gangrene was relatively superficial, and with time, the lesion healed. In this case also, ischemic diabetic feet, one can notice abnormal skin color, poor hair growth, and there was significant difference in the temperature when below knee region was compared with the toes. For example, on the left side, below knee temperature was 34.6 degrees, while at the toes, the temperatures was 31.2. So the periphery was cooler. The toes were cold because of peripheral vascular disease. Similarly, on the right side, below knee, temperature was 34.2, while at the toes, the temperature was 31.2. So it's not appropriate to do debridement in this type of case. There is abnormal skin color, poor hair growth, and the skin is cool. So the appropriate decision is to leave the devitalized tissue to dry to such an extent that the necrotic tissue separates. And with time, as one can see, the lesion healed. In the first picture, the lesions are there, and in due course, the lesions healed without debridement. In this case, debridement is clearly needed to remove the slough and dead tissue, and the margins were cleaned. The wound bed was cleaned, the margins are being cleaned, debridement is being done, and in due course, the lesion healed. In this case, the lesion was there, debridement was done. Footwear change played a major role in the management of this particular case. Serial dressings were done, serial debridements were done in this particular case, and the wound bed was cleaned, the margins were cleaned, and in due course the lesion healed. Infection control played a major role in this case, and in due course the lesion healed. In this case, the main points were debridement, regular dressings, and patience. So as one can notice, surgical debridement was done, the wound bed was cleaned, and in due course the lesion healed completely. In this case, the main factor which led to healing was infection control along with debridement and metabolic control. In this case, in the first picture, as one can see, the lesion is there, debridement was done, footwear change was done, and the lesion healed. In this case of gangrene, debridement was avoided. The main factors which contributed in healing were antiplatelet therapy with statin, atorvastatin, aspirin, clopidogrel, and good metabolic control. Similarly, in this case, as I had shown earlier, debridement was avoided. Antiplatelet therapy with statin, aspirin, clopidogrel, and good metabolic control helped us to prevent the amputation. In this case, metabolic control, infection control, renal parameters were managed to control the edema, and the lesion was healed and amputation was prevented. Similarly, in this patient, the main factor contributing to healing was infection control. Similarly, in this patient, in this case, debridement played an important role. The lesion was cleaned, slough was removed, wound bed was cleaned, and the lesion healed. In this case, serial debridements were done, regular dressings were done, metabolic control and patience, and with time, the lesion healed and amputation was prevented. Callus plus infection, main role was debridement, metabolic control, offloading, and dressings, and the lesion healed. In this picture, in this case, lesion was there, debridement was done, footwear change was done, and infection control and lesion healed. In this case, it is a high risk for great toe amputation, but debridement was done, infection control, and the lesion healed. So in this brief lecture, I have covered what is debridement, why is it necessary, what are some of the options, who does the debridement, when to avoid debridement, and I have shown you some of the cases from my diabetic foot clinic in Lucknow, India. Thank you very much.